Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
There's an increasing use of cannabinoid products, both recreationally and medicinally, especially, but by no means exclusively, in young people. Many of our patients have tried cannabinoids to help with various sleep disorders. So, to discuss cannabinoids and sleep, my guest today is Dr. Bhanu Kohler, Professor of Psychiatry at the Mayo Clinic College of Medicine and Science, and a board-certified specialist in both areas, sleep medicine and addiction medicine, so an ideal person to discuss this area. So, Bhanu, the brain and the body are primed to respond to exogenous cannabinoid compounds because there is a little known physiologic endocannabinoid system with receptors in both the nervous system and other organs. Tell us briefly about this system. What are these receptors and what role do they play in normal function before we come to exogenous cannabinoids?
Sure. Thanks so much for having me, Mike. This is always an interesting topic. So like you said, we do have an endogenous cannabinoid system. We discovered this actually in the 80s and 90s, while the cannabis plant and cannabis products have been available for millennia, and people have been using it both for medical reasons and also for various religious purposes. We still don't completely understand what the endogenous cannabinoid system does. We have two main receptors. There is the endogenous anandamide. Anand is Sanskrit Hindi for happiness. So that's one of them. And 2-AG is the other system. We think it plays a role in various homeostasis. So it seems to control appetite, sleep, but also cognition and immunity. But it seems to have multiple other functions too, which are still being delineated.
Well, part of the difficulty in understanding exogenous cannabinoids is this multitude of compounds and the fact that, with very few exceptions, there are no pure entities available pharmacologically with well-defined pharmacokinetics. For example, as I understand it, the cannabis sativa plant has more than 500 compounds, including more than 125 phytocannabinoids, and that's enough to make anybody's head spin with or without cannabinoids. But the best two compounds that are best known are CBD and THC. What are these chemicals? Help us understand their differences.
Sure. Like you said, the cannabis plant as such has many compounds. And what complicates things is research conducted with the plant. You have no idea how much THC there is, how much CBD there is. And there is also this whole concept of what's called the entourage effect, where if you're using multiple compounds in combination, they could be doing something quite separate and different from each compound by itself. CBD is not thought to be psychoactive. THC, so tetrahydrocannabinol, is what we think is the psychoactive component, which gives people the high. There is also CBG and a few other compounds which have been studied a little bit, but we don't completely understand the role that they play. With THC, that seems to be the compound that is most likely interacting with the sleep systems and causing the sleep effect. So from a sleep standpoint, that's what we're mostly interested in. And with CBD, the thing to keep in mind there is that it can be an enzyme inducer, as can THC. So when you're using that in combination, that could be a problem, especially people on other medication. One final thing to know is a lot of cannabis is now available as medical grade cannabis, but this again is not regulated. So it's very unclear as to whether the patients are actually getting what the label claims they're getting, and if it's at the right dose, and if there are no contaminants. So it's a complicated field with a lot for us yet to learn about.
So, before we come to the possible use of cannabinoids for sleep disorders, let's explore their effect on sleep architecture. Tell us about what studies have shown about acute changes and people who are users of cannabinoids, the chronic changes in sleep architecture.
Again, here the data are not very clear because of all of these complications that we talked about in terms of not having pure compounds that are available and in terms of what you might get when you're using recreational cannabis products as compared to pure cannabinoids. What we do seem to know is CBD seems to have very little to no effect on sleep architecture or any kind of sleep parameters. Most of the
Mhm.
data seems to suggest that the effects come from THC. With THC, like you just alluded, occasional users seem to note that they fall off to sleep a little quicker, maybe get a little more sleep than usual, but that's about it in terms of the effects that we know about in occasional users. In chronic users, this effect seems to plateau or you develop a tolerance, and there doesn't seem to be that much that chronic users seem to notice in terms of sleep changes, at least objectively. When people are chronically using THC or other combination cannabinoid products and stop, that's when we actually see most of the effects. So at that point, we think what happens is there is an increase in REM sleep when they stop using. So people seem to go into REM sleep quicker and get more REM sleep. Interestingly, this doesn't consistently translate to REM suppression in acute use.
So, if we're not really quite sure what it's doing to sleep architecture, are there studies which do in fact show benefit, at a clinical level studies? I know there was one study of 9,000 participants who said, we're using cannabis medically. 47% of them said the reason was insomnia. So there's certainly a feeling out there that it's helpful for insomnia. Are there trials which show whether this is so or not?
So most survey studies which have looked at people who have been using medical cannabis, so cannabis for medical purposes, the main indication usually is pain, followed by sleep problems or a combination of the two. So insomnia or sleep disturbance is extremely commonly cited as a reason people gravitate towards medical cannabis products. The control trials are actually quite few, and none of them have convincingly shown that it helps with insomnia or sleep disturbance as such. In terms of the epidemiological studies or survey studies, the overwhelming evidence actually is that there seems to be more sleep disruption among chronic cannabis use, even if it is for medical reasons, and even if that medical stated reason is insomnia, there seems to be more sleep disturbance there. But again, few studies, I would say that there are some, not zero, and none of them have convincingly shown that it actually helps with insomnia.
Okay, well, then a second reason some people try cannabis has been PTSD related nightmares. Is there any evidence that cannabis helps for this distressing condition?
There isn't. There actually was a very well done randomized control trial in the veteran population where they used smoked cannabis in various doses, and really it did not separate from placebo. So that was a pretty convincing negative study showing that it doesn't seem to help.
Disappointing. Okay. Then one of the more controversial users has been to treat obstructive sleep apnea. And well, the state of Minnesota, I'm not sure about other states, has actually approved obstructive sleep apnea as an indication for prescribing medicinal cannabis. However, the American Academy of Sleep Medicine and many sleep specialists do not recommend it. In fact, I think we wrote a letter in from our sleep center saying be very cautious about this.
Mhm,
Tell us about the studies that have suggested that it helps sleep apnea. I mean, what is the quality of the studies? What were adverse effects?
mhm. So these studies, first off, used dronabinol, which is a synthetic THC analog. So none of these studies used THC per se or smoked cannabis. There were initial observational studies, open label trials, which showed that there could potentially be some improvement in the AHI in patients who were on dronabinol, which led to what's called the PACE trial, where they used dronabinol again in patients with obstructive sleep apnea at various doses, 2 to 10 milligrams, compared it to placebo. The study is reported as a positive study where there was an improvement in AHI as compared to placebo. But the main problem with this study is the difference is mostly driven by an increase in AHI that happened in the placebo group as compared to the reduction in AHI in the active or dronabinol group. And if we were to just look at the raw numbers, there was an improvement in AHI of about 2 to 4. So this, all of us, I think, would agree from a clinical standpoint is not particularly meaningful, a 2 to 4 reduction in AHI. So based off of this study, unfortunately, people applied for, and Minnesota did grant this license for medical cannabis to be used for the treatment of obstructive sleep apnea. Like you said, the American Academy of Sleep Medicine and our group also wrote letters both to the Department of Health at the state of Minnesota. So the condition still stands, but they do have this paragraph when people look this up within their website that there are other treatments and they should be trying those first. It is particularly worrisome for us as sleep clinicians because we know that obstructive sleep apnea causes daytime sleepiness and increases the risk of motor vehicle accidents. Use of cannabis also causes daytime sleepiness, also increases the risk of motor vehicle accidents. So that can be a double whammy. And I think at this point, there isn't any convincing data to suggest that it can be effective for obstructive sleep apnea.
Many of my patients with severe restless leg syndrome have said they've tried cannabis. Is there evidence for its use in RLS?
So I'm going to initially talk about REM sleep behavior disorder. I don't know if you were going to ask about that, but I'll sort of tie it to the restless legs in that there were some case reports and case series showing that people found that cannabis products were helpful for REM sleep behavior disorder. That led to a trial, a randomized control trial, where people tried cannabis products and especially THC, compared to placebo in a blinded fashion. And there they showed that really there was no effect of the cannabis products to treat REM sleep behavior disorder. With restless legs, there are case reports and case series showing that people who have been using cannabis products reported significant improvements. But like with RBD, I would say that till we have good quality randomized control trial data that has been replicated, it is still very early days. We need to wait for that before we can recommend any of those.
Most of my patients who've tried it have given up and said that it's helpful sometimes acutely for half an hour after using the product, and then it wears off if it's helpful at all. So yes, that would seem reasonable. Well, you've alluded to the fact that for almost all these conditions, the standard of studies has really been poor, and the number of studies have been very few. With this huge use of cannabis compounds and the legalization of them across so many states, would you like to speculate why there have been so few adequate studies?
So for the longest time, the problem was cannabis has been Schedule 1 drug by the DEA. So what that means is they claim, based off of that scheduling, that it has a very high risk of misuse or abuse and no medical purpose for its use. So that substantially limits our ability to do studies on this. That has limited the number of studies, but I would say that there have still been some. So at this point, I don't think the evidence is zero, but what evidence we have hasn't shown anything convincing in terms of an effect with any of these sleep disorders. I think the evidence base will continue to build, but at this point, based off of what we have, I feel reasonably confident in saying that there seem to be no sleep disorders for which cannabis can safely be recommended at this point.
Well, that's pretty definitive, but let's talk in addition about adverse effects, firstly of acute cannabis use. What are the possible consequences of acute use that aren't so good?
So with acute use, we know that it delays reaction time and increases the risk of motor vehicle accidents. Especially when the doses go too high, cannabis can induce psychosis, and it's pretty hard to tell the dosage based off of the labeling. So that is another risk. We also, in our addiction world, see a lot of inadvertent overdoses, especially among children or other vulnerable adults who have taken gummies or other edibles, which look very similar to other candy and products that people use. So that's the other thing to keep in mind with acute use.
And with chronic use?
With chronic use, there is very convincing evidence that it increases the risk of developing a primary psychotic illness. So whether that's schizophrenia or schizophrenia-like illnesses, especially with consistent large quantity use. And this is an especially high risk for people who still have developing brains, so adolescents and those younger than 24. So that's the chronic use risk. There are more rare conditions we see occasionally, cannabis-induced hyperemesis, where people have vomiting that comes on, quite severe recalcitrant nausea and vomiting that cannabis can cause. Um, there is now data to show, especially with smoked cannabis, that it can be a risk factor for lung cancer. We talked about drug interactions. And with cannabis use, when people stop, there can be significant sleep disruption too.
So, well, first to say, my daughter, who's an emergency medicine physician, says that when she sees frequently young people coming into the ER with intractable vomiting, and by far the most prominent cause is cannabis. So that may be more common, you're seen in an ER population than in an addiction population.
Mhm.
Um, in terms of it predisposing to psychoses, are we sure that it does, and that it's not just that people who are predisposed to developing psychoses are more prone to be using higher and larger amounts of cannabis?
So this is still up for debate. So there could be the same pathway genetically. So whatever is predisposing you for a psychotic illness is also predisposing you to use cannabis. So that's one theory. The other is the whole self-medication theory, in that maybe there could be some people who gravitate to cannabis products to treat some of their psychotic illness. But I think there are multiple studies right now which have shown that people who use cannabis regularly are at greater risk. The greater the quantity of use, greater the risk. So whether it's causing, unmasking, bringing forward, all of those could possibly be reasons why we are seeing this increased risk. But it is safest for people with developing brains and also those who are genetically at high risk to avoid cannabis products.
Tell us about urine tests for cannabis. Are they helpful? And specifically, how long do they stay positive after acute use?
They can be. So the way we think about urine drug tests in addiction is that they're a tool. They give us information, and that information has to be seen in the context of the entire clinical picture. So trust but verify is how I'd put it with the urine drug tests. Usually with very occasional uses, you could within 3 days completely clear out cannabis. A little more frequent use, roughly we see it for about 7 days. For long-term users who are heavy users, urine tests can be positive for up to 4 weeks. We use a lot of quantitative measures too in our addiction practice. So when people are heavy users and have stopped, we can get quantitative data to show that over time the quantity is going down. So that is, they have stopped, but they're still testing positive.
So extreme caution for non-experts to interpret these urine tests would seem
Yes, and
sensible.
yeah, speaking with an expert, a toxicologist always is a good idea in these situations.
Well, Banu, thank you for sharing this expertise. Do you have any final messages to leave with our listeners?
Sure. So I think this comes up quite often. Um, does it need to be Schedule 1? I think that's a political question rather than a scientific question. It is pretty clear that compared to some other compounds that are legal, like alcohol and tobacco, which cause a lot of health consequences and other consequences, maybe cannabis is not so bad. But that said, when it comes to medical uses, again, I don't think there is any convincing data to suggest that there are clear medical purposes for us to be using cannabis products. There is some data to show it can help with spasticity, it can help with nausea, vomiting in the context of HIV, chemotherapy, cancer treatments. Outside of that, the data are very weak. We need to develop that evidence base, I agree, but I don't think that there is at this point enough evidence for us to be using cannabis products, especially when there are other evidence-based treatments available for most of these conditions, and especially for sleep disorders. And one final thought is people who regularly use cannabis and stop, when they come to see me, especially in my addiction practice, tell me that I know that it works because when I stop, my sleep deteriorates. So when I'm using, I'm sleeping better. But there, what is especially hard is to tease out the withdrawal effects, because when you stop using cannabis after regularly using it, sleep is disrupted and stays disrupted for about 2 to 4 weeks. So educating patients to give themselves that time to see actually if there is any benefit versus not.
Well, thank you very much. We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.